Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article, number 8 and number 9. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. While it seems tempting to skip ahead to discover the treatment that I recommend, you will miss the value of the clinical journey that I am sharing with you. Article number 8 and article number 9 will be combined into this podcast. Pain is not the only problem. Define pain, Part 1 and Part 2. These articles intend to 1. Reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms. 3. Meet patient expectations and satisfaction and clinically meaningful results. 4. Recommend a conservative non-surgical course of care to override pain instantly. And 5. Restore ADLs and patient confidence on the first visit at low cost. Since pain is a subjective experience, clinical definitions vary widely. Consider these attempts to define pain. Yam et al. 2018. A concept of sensation that we feel as a reaction to the stimulus of our surrounding, putting us in harm's way and reacting as a form of defense mechanism that our body has permanently installed into its system. Smith 2018. Pain results from the activation of a subset of sensory neurons termed nociceptors and has evolved as a detect and defend mechanism. However, a lesion and disease in the sensory system can result in pain that serves no protective function. Again, Smith 2018. Nociception is the neural process of encoding noxious stimuli, whereas pain is defined as an unpleasant sensory and emotional experience. Brodall 2017. We must distinguish between the experience of pain and the meaning that the person gives to it. The person's beliefs about the cause of the pain may be right or wrong. Punjabi 2006. The exact cause of most low back pain remains unproven. Salto et al. 2018. Phantom limb pain is associated with neither damaged tissue nor an inflamed body part. Dean 2016. The pain signal is exposed to a wide variety of influences and is never an exact or predictable or reproducible representation or presence of genuine or patient-imagined tissue damage and can never be seen or diagnosed from a picture. I'm going to say that one again because I own it. The pain signal is exposed to a wide variety of influences and is never an exact or predictable or reproducible presentation or presence of genuine or patient-imagined tissue damage and can never be seen or diagnosed from a picture. Well, so when we're talking about a picture, we mean plain film and advanced imaging. Pain is a story, an idea, an interpretation. Pain can't be objectively demonstrated. When the clinician touches the area of the patient's complaint and the patient says, ouch, the origin of the pain is not located at the touch site. The origin of pain is located in the brain, an experience interpreted by several factors related to the touch site. Pain does not originate nor occur at the injury. A signal is generated at the touch site, a signal called signal X. Signal X is delivered from the touch site along a series of 3 nerves. First, from the touch site tissue to the dorsal root ganglion. Then, the signal jumps the first synapse at the dorsal root ganglion and onto the second nerve cell. Any levels 2 to 4 or above or below that specific nerve root level, where it either ascends on the same side, ipsilateral, or on the opposite side, contralateral of the spinal cord. Then the signal X jumps the second synapse at the thalamus onto the third nerve cell and is delivered to the cortex, or the cognitive brain, where the final synapse to be evaluated for touch depth quality, touch area qualities, temperature, vibration, joint position information, muscle tone information, and nociception, a signal with pain experience qualities. At each of these three synapses, 45 or more chemoelectrical reactions occur to preserve the exactness of the signal. What are the chances of that? These signals X, any of these what I call sense signals, arrive at the brain from all over the body, billions of nerves, 24 hours a day with no interruptions, only one of which is a perception of pain, nociception. However, the nociceptive signal does not always arrive at the cortex in its purest preserved form, and other signals arriving at the cortex can be confused for nociceptive signals. Test question: can the body experience pain? The answer is no. Only the brain has the experience of pain, then assigns it back to the most logical area of the body. When the patient says, "It hurts here," the clinician is not going to correct them. However, the clinician needs to be careful when treating pain at the site of the injury, and remember that the pain is a lived experience within the brain only, an interpretation, a story. The experience of pain is always real and can be life-altering for the low back patient, an undeniable truth. The patient's greatest fear is that the pain will never go away. Clinically, however, pain should be understood differently, less as a symptom and more as a corruptible nuisance. Pain is not the only problem. Sometimes it is the clinician's understanding of it. Part 2. The human goal is not the removal of pain, but the restoration of happiness. And we can thank Gilbert 2004 for that statement. According to Dan Gilbert, the prefrontal cortex is an experience simulator developed this way only in humans. The prefrontal cortex possesses an impact bias as a simulator that generates biases on personal outcomes. It is a predictor, and it can do it without any input at all. For example, would liver and onion flavored ice cream taste good? How about this one? Would you rather win $314 million or get a hot fork stuck in your eye? According to Gilbert, getting something we want matters more than what it is. The free choice paradigm. I'll say it again. According to Gilbert, getting something we want matters more than what it is. The free choice paradigm. There is nothing good or bad. It is the permanence of a condition that is feared. So we become prudent, cautious, and thoughtful. And we have the ability to manufacture the thing we are attempting to avoid. Low back pain patients are notoriously blaming themselves for causing their own back pain. Patients and their doctors are commonly searching for the cause, the one event, the incident, as the mechanism of injury. Pain equals bad. Low back pain clinicians are notoriously blaming advanced imaging findings for causing low back pain. Clinicians are commonly searching for the disc bulge, the disc height, and the pinched cord, and bony changes, as described illustriously in imaging reports. Picture equals bad. Picture equals pain. Without much argument against the point, clinicians likely agree that all non-traumatic low back pain is insidious, uncomplicated, likely due to personal behaviors, lifestyle habits, and the resistance of the patient to face the work to strengthen their relationship with physical activity and diet. The patient's low back pain becomes the calling card for self-realization that they are failing to control their own pain problem and have likely caused it? Can the patient simply skate past accountability by blaming the pain as being the problem and not themselves? Not only patients are skating past accountability, clinicians are too. I personally saw 3 different physicians over 5 years for my low back pain. To date, I have not been diagnosed, never received a treatment plan, either long-term or short-term, never been examined in any way, never been asked about my lifestyle, sports, activities, how I use my body, nor asked any historical questions about my occupation. The longest time I spent in a doctor's office was on my first encounter with the first doctor, 3 minutes and 14 seconds, and he took no chart notes. I have had x-rays, re-x-rays, MRIs for different areas, low back, my hip, my legs, blood work for ankylosing spondylitis even when my x-rays did not support it, 3 surgical referrals and a prostate exam. I got the runaround. If the doctor can't find anything on the picture, they are at a loss. Picture equals bad again. Explain the convenience of observing degenerative changes and associating them with a complaint of pain. But when there are no observed degenerative changes, pain can't be explained. And when there are degenerative changes observed, what do you do with a complaint of no pain? Is this clinical convenience? What about a third answer that makes the pictures go away and where diagnostic accuracy is not about clinical convenience? What if we can reframe diagnosis to be based on function and not fiction? Fiction, a belief or statement that is false, but that is often held to be true because it is expedient to do so, an allegation, an invention. Wikipedia 2016. Chatterjee 2018 has this to offer. Somatosensing and microtransduction is the conversion of mechanical forces into biological signals, a process that reveals environmental features to an organism. Dysregulation leads to peripheral neuropathies. Muscle listening and signaling can warn the body, just as nociception does. Gupta 2018 offers us this. Transient signaling can be interpreted as chronic signal inconsistency. Jensen 2018 offers us this. The reductionist approach can never fully explain persistent pain. Yang et al. 2018 offers us this. Recent research has shown that innervation of the lumbar IVDs does not necessarily correspond with innervation of the spinal nerve segment, but are innervated by multiple different segments from the dorsal root ganglion, and the sympathetic trunk constitutes an indirect pathway for lumbar disc nerve conduction. Wexler et al. 2007 offers us this. MRI imaging techniques are not always helpful because they have a poor degree of correlation with clinical signals. Imaging supports the diagnosis, but the reverse is rarely true. The search to clinically define and explain pain may be a painful search. Common clinical practice is used to imaging to explain pain, likely due to its efficiency. However, there are many contributors to pain that can't be seen on imaging, such as subthreshold microtrauma, sympathetic compensation to associated dysfunction, faulty motor patterns, frustration, worry, fear of pain, for example. Pain is not the only problem. Can you think of any other areas of the brain that might light up along with a pain signal? Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.